كمان بهاي المناسبة الحلوة كم زميل عمل الامتحان ونجح؟ مبروك زقفة كبيرة اليوم. نتمنى تكونوا على طريق النجاح وطريق التفوق والاستقلالية بالعمل، يكون في لكم هوية مهنية واضحة. بنرحب كمان بالدكتور جوزيف ماسكولينو، هو إيطالي الأصل أمريكي الجنسية، دكتور كايروبراكتيك لأكثر من 35 سنة، مؤلف ل8 مؤلفات في منها أخذ عليها جوائز، وكمان هو كان مدرس في جامعة في نيويورك ومحاضر دولي. هو أجى على فلسطين المرة هاي المرة السادسة أو السابعة تقريبا. احنا أخذنا مساق السباينال موبيلايزيشن. رح نكون بكرة وبعده في مؤسسة الرئيس بوتين ندرس الكورس كمان مرة، وفي حيفا للمرة الثالثة. أنا اسمي ميسة بوردية اللي ما بيعرفني، رئيسة المركز فيزيك كلينيك اللي هو مركز متخصص لعلاج اليدوي، متخصصين بالعمود الفقري، منطقة الحوض السيدات، كمان المفصل الفكي، وكمان متخصصين بالتطوير المهني. إحنا بنعمل دورات لمدة حوالي 3 سنوات أو 4 سنوات في كثير مجالات. تقدروا تفوتوا على الصفحة وتتعرفوا على نشاطاتنا. أوكي، welcome دكتور جو.
Okay, can everyone hear me? And I'll try to speak nice and slowly so that there'll be no problem with the language, okay? Good? Very good. Okay, so thank you very much for inviting me to give this 1-hour overview lecture on the psoas major muscle. And this was decided last week, so this is all last minute. I have a short PowerPoint, and we're going to cover some back feeds into. Can this be shut off? Let's shut that off. See if that's better. We'll see. So we're going to cover 3 aspects for the Psoas major. We're going to cover the mechanics, in other words, the function of Psoas major, and that will be the first third, perhaps about 15-20 minutes, and then we are going to address how to assess it with palpation and work it with soft tissue manipulation, massage, and then how to stretch it. If you have questions as we're going, I invite you to please ask those questions, okay? Everyone here is a physiotherapy student or fitness trainer, is that correct? Okay, who here is in first year? The first year. Who here is second year? Third year? Fourth year? Okay. 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 So, the psoas major attaches to the anterolateral bodies of T12 through L5 and the discs between the bodies of the vertebrae and the transverse processes of L1 through L5. So it goes all the way from thoracic spine through lumbar spine, then it travels deep to the inguinal ligament to attach distally onto the lesser trochanter of the femur. The psoas major is shown on the left side in this figure. Is that better now? Now there's still, if I go somewhere else, and you'll change the slides. Okay. And is the camera story? Okay, so the psoas, this is much better. So the psoas major, we can see it on the left side here, and the iliacus, another hip flexor muscle, is drawn in on the left side, and we see the iliacus on the right side. Just for naming, because the psoas major attaches onto the lesser trochanter, and the iliacus attaches onto the lesser trochanter, then some books will describe the two muscles together as the iliopsoas. And for the hip joint, they're both flexors of the thigh at the hip joint, or anterior tilters of the pelvis at the hip joint. So it's okay to group them together as one muscle for the hip joint. But the iliacus has nothing to do with the spine. So for the spine, they are two very, very different muscles. So they really should not be grouped together. So before we go into the functioning of this muscle, let me just first take a moment to say why this muscle might be important. So first of all, it is one of the major flexors of the thigh at the hip joint. There are 12 flexors of the thigh at the hip joint, from lateral to medial. Anterior fibers of gluteus minimus, anterior fibers of gluteus medius, tensor fasciae lati, TFL, rectus femoris, sartorius, iliacus, psoas major, pectineus, adductor longus, adductor brevis, adductor gracilis, and the anterior head of adductor magnus. There are many flexors of the thigh at the hip joint. Psoas major is one of them that is fairly powerful because it is large, but it does not have a very good lever arm or moment arm. So it's not super powerful as a hip flexor, but it is fairly powerful. It's more important because of its functions across the spine. It pierces the diaphragm to get up to T12. Some of its fibers attach into the diaphragm, so it can help stabilize the diaphragm. It crosses all of the lumbar spinal joints, and we'll talk about its function there, especially in the sagittal plane of flexion and extension, which is quite important. It crosses the hip joint, it's a hip flexor. It sends fibers into, I think, be careful. I think if you move there, it moves the, here, just take a step for a second. Let me try to see. Sometimes it shakes. Okay. Oh, it's the projector? Okay. So it has fibers that go into the sacroiliac joint, so it also helps to stabilize the sacroiliac joint, and it has fibers that go into the pelvic floor musculature back here. So it helps to stabilize the diaphragm above, the pelvic floor below, the sacroiliac joint. It functions with the lumbar spine, and it functions with the hip joint. So that's a lot of functions for one muscle to have. So it can have this function that can create low back pain, low back instability, can perhaps create problems with a disc, etc. So this muscle is very involved with any problem from the diaphragm to the hip joint. So for me, in practice, any patient that comes in with any low back problem or hip joint problem, I will assess this muscle. I will palpate it and assess it. And you could also muscle test its strength. But I will physically, in the exam, assess this muscle. If the muscle is perfectly healthy, then it's not part of the problem. You do not need to worry about it. But if you palpate it, or you muscle test it, you find that it's tight, or there are myofascial trigger points in it, or it's tender and painful to the person, or it's weak, then perhaps you should do something in your treatment plan for it. So, is that okay as an explanation of why the psoas major is important and perhaps you should at least assess it? Are we good? Wonderful. Okay, so just to show another picture, this shows it close up, and on the right side, our left side, the patient's right side, we can see, this is a superficial view, all of the hip flexors are shown here. There's the ASIS, anterior superior iliac spine, sartorius. Here we have sartorius, there's tensor fasciae lati. Right after sartorius, we have the iliacus, and then the psoas major right there. Abdominal belly, or you can say abdominal pelvic belly, and then femoral belly. It is not ligament after it passes deep to the inguinal ligament. The psoas major is still muscle belly when it passes deep to the inguinal ligament. So it's still muscle tissue belly here. It only becomes tendinous when it gets very close into the lesser trochanter. And just to point out here for later, the femoral nerve, artery, and vein overlie in this what's called femoral triangle, overlie the psoas major. Okay? Nice. Okay, so we have here a right lateral view. And in this right lateral view, the psoas major is attaching up higher on the spine. We can see some attachments go into the bodies. Some attachments go into the transverse processes. Is this speed of English good for you? Yes? What's that? Good enough? As good as it will be for you. Okay, and it runs down to attach out of view on the lesser trochanter of the femur. So we can see it crossing the spine and the hip. If we want to understand the function of a muscle, it is very, very simple. It is much simpler than most people realize. A muscle is a pulling machine. That's all it is. When a muscle is told to contract by the nervous system, the muscle pulls toward its center. It pulls equally on both attachments. The muscle does not intend to move one attachment more than the other. It pulls equally on both. Which attachment moves is the one that has less resistance to moving. If we are looking at the hip joint as an example, if I have a muscle that crosses the hip joint anteriorly, so you have an axis through the body, an axis that is running horizontally, left to right, right to left, a medial-lateral axis. Any muscle that crosses anterior to that will either flex the thigh at the hip joint or will anteriorly tilt the pelvis at the hip joint. If the foot is free to move, the distal element of the kinematic chain of the lower extremity, pelvis, thigh, leg, foot. The foot is the distal end. If the foot is free to move, then the distal end is free to move, and you have open chain kinematics, and you get flexion of the thigh at the hip joint. And we call these muscles, go back one slide please. We call these muscles hip flexors. But a patient comes into your office, into your clinic. If the patient has a tight psoas major, tight iliacus, any hip flexor muscle is tight, and they stand there in front of you, they are not going to stand there with one thigh flexed out in the air, which would be flexion of the thigh at the hip. What's going to happen is their foot's on the floor. They're in closed chain kinematics. The distal attachment now has more resistance to moving toward proximal than proximal does toward distal. So their pelvis will anteriorly tilt at the hip joint. Now they're going to be in this posture. Well, this posture, I'm looking at the floor. I'm not going to be able to function in this posture, so I will have to compensate. I will increase my lumbar lordotic curve of extension to bring my eyes back up to level, my inner ears back up to level. Now, because I have tight hip flexors, I have a hyper lordotic lumbar spine, which means I am shifting my weight from anteriorly on the discs to posteriorly on the facets. That's good for your discs. You decompress them. It's bad for your facets. You compress them. Now, you might have low back pain because your facets are jamming. Right? So there's an example where if your hip flexors become tight, you will not stand with your feet in the air. You will change the posture of your pelvis, which will then change the posture of your lumbar spine, which will then change the posture of the thoracic spine, which will then change where the posture of your head is. Like dominoes falling, you can take this concept and you can basically say, tight hip flexors will create an excessively anteriorly tilted pelvis, a hyperlordotic lumbar spine, this is called lower cross syndrome from Vladimir Janda, a hyperkyphotic thoracic spine, a hypolordotic lower to middle cervical spine, hyperextension of the head at the atlanto-occipital joint, and forward head posture with the center of weight of your head over thin air, which means it should fall into flexion, except that your posterior cervical cranial extensors, all of the muscles back here, now must isometrically contract every waking second and minute of the day to keep your head in this imbalanced posture. Now these muscles get tight. Because they get tight, they pull at their attachments on the scalp. Then you get a tension headache. It stretches out the lower to middle cervical spine will now actually be shortened, and then the hyperextension of the head will pull on the suprahyoid muscles, which will stretch out on the hyoids, which attach to the mandible, which therefore affects the temporomandibular joints, the TMJs. So you can argue that a tight psoas major or a tight hip flexor of any sort can cause TMJ problems, can cause headaches, can cause neck pain, can cause thoracic pain, can cause low back pain. And if I stay like this all day, my pecs get tight. My pecs get tight, now I protract my shoulder girdles. I immediately rotate, internally rotate my arms, my humeri at the glenohumeral joints, and now the posture of my shoulder joint is unhealthy. If I'm in medial rotation, I'll invite you, if you have room, to do this without hitting the person next to you. Please do this. Medially, internally rotate one arm at the shoulder joint. Do that, please. Go ahead. Come on, you can do it. All right, sit up. Just go ahead and do it. You can stand. Now, are you the model? Face the class. Okay, how much abduction? How far should the humerus be able to abduct? 180 degrees, okay? 120 of it's at the glenohumeral joint, 60 degrees of it is scapulopostural joint, but the whole thing is 180. Immediately rotate as far as you can. Slowly start to abduct. Go, go, go. How far can you go? That's as far as you can go. Yes? Okay, now, laterally rotate. Go the rest of the way. Can you go more? Okay. Thank you. My point is this. If you are medially rotated, the greater tubercle on the head of the humerus will hit the acromion process. If you laterally rotate, you take the greater tubercle out of the way, the lesser tubercle is smaller, and you can go the rest of the way. If someone has this upper crossed syndrome posture, then the medial rotation of the humerus means that they cannot raise their arm to the side, abduction. When they do, they will impinge, they will compress, they will pinch. The supraspinatus distal tendon, the long head of the biceps brachii, the subdeltoid subacromial bursa, and the craccohumeral ligament. Then they get impingement syndrome of their shoulder. Why? Because they're protracted and medially rotated. Why? Because they're hyperkyphotic. Why? Because they're hyperlordotic lower. Why? Because their pelvis is anteriorly tilted. Why? Because their hip flexors are tight. A problem at the hip joint will play out with posture of the pelvis, and that will affect the posture of the spine. I spent much more time on that than I expected. Okay, so let's go forward. So, if we are looking at what the psoas major does, all we need to do is say a muscle is a pulling machine and it can pull both attachments. The psoas major, actually go back one please. The psoas major crosses the hip joint anteriorly. There is no doubt about that. There is no controversy. The psoas major flexes the thigh at the hip joint. If you're closed chain, it can anteriorly tilt the pelvis at the hip joint. Sagittal plane, hip joint, done. Any questions? Okay. No? Okay. Can you forward? Go forward. Go forward. Stay there. Now, the ability of a muscle to be able to do a joint action is based on its line of pull relative to the axis to the joint. How strong the muscle is based on how large it is, its physiological cross-section, and its lever arm, its moment arm. The moment arm is the distance from the axis to the joint perpendicular to the muscle. The psoas major is strongest between 45 and 60 degrees. Around 50 degrees, psoas major is strongest. In anatomic position, it's not a very strong flexor of the thigh at the hip. But as you begin to flex more and more, the line of pull moves farther away from the joint, farther from the axis. It becomes more powerful. Okay, forward please. Let's go past that. And okay, go past that. Okay, if we take a look at the hip joint and say, okay, sagittal plane flexes. What about frontal plane and transverse plane? In the frontal plane, for abduction, adduction, the psoas major's line of pull is almost right over the joint, which means it has almost no ability to abduct or adduct. But if you start in abduction, the line of the muscle goes lateral to the joint, and then it becomes an abductor. And the farther you abduct, the stronger it becomes. If you adduct, the line of pull goes to the medial side, and it becomes an adductor, AD. If you laterally rotate, the line of pull of the muscle moves more lateral, and it becomes an abductor. But it's not strong as an abductor or adductor. Gluteus medius is much stronger way out lateral. Adductor, brevis longus magnus are much stronger, more medial. As far as rotation, it's very weak with rotating the hip joint. Once you laterally rotate, it becomes a stronger lateral rotator, but it's not very strong there. There are many other muscles that can laterally rotate the thigh at the hip joint. Gluteus maximus, posterior fibers of gluteus medius, gluteus minimus, sartorius, the deep six, piriformis, and the other five. Okay? So it's not a strong rotator either. The only major function at the hip joint is flexion and reverse action, closed chain, anterior tilt. Okay? The only major function of the psoas major at the hip joint is flexion of the thigh at the hip, open chain, anterior tilt of the pelvis at the hip joint, closed chain. That's its only major function at the hip joint. Good? Okay, so now we go back to the spine. Can we go backwards? Stop. Perfect. There is no controversy on the frontal plane function of psoas major at the spine. It's to one side. The right psoas major is on the right side of the spine. It's a right lateral flexor. It's an ipsilateral lateral flexor, a same side lateral flexor. No controversy. It's not as strong as muscles that are way out here, like the lateral fibers of external abdominal oblique, internal abdominal oblique, quadratus lumborum, but it can do lateral flexion. For rotation of the spine, if you take the attachment on, let's say, the transverse process and move that attachment toward the lesser trochanter, you will get a contralateral rotation of the trunk. So the psoas major can rotate the spine to the opposite side of the body. It's not strong, but it can do it. But these secondary joint actions can matter when you want to stretch somebody. And we'll get to that a little bit later. So we only have one function left to look at for the spine, and that's the sagittal plane. Is it a flexor or is it an extensor? So can I get a show of hands? Can you please tell me? Raise your hand. Is psoas major a flexor of the lumbar spine Raise your hand. Flexor? Is it an extensor?
بسأل إذا البسوس بتعتبروها هي فلكسر للسباين ولا لا؟ اللي بيقول يرفع ايده.
So raise the hands for flexion.
اللي بيقول إنها بتعمل فليكشن على السباين يرفع ايده.
Right now I'm not asking about the hip. I am only asking about the lumbar spine. The joint action of psoas major at the lumbar spine. Is it flexion or is it extension? Okay, so I ask them to raise their hands if at the lumbar spine it's a flexor.
إذا البسوس ميجر عن اللمبر سباين هي فليكسر ارفع ايده.
Okay, is it an extensor?
هي extensor.
Okay, you're both right. It's a flexor. What? Lateral rotation. Wait a minute. The lumbar spine does not laterally rotate. It can right rotate or left rotate. So what is your question?
في مجال ولا جنبته؟
For flexion and extension. We're back to. Okay. Okay. So, nice. Can you go? I'm not sure. Go backward. Let's see. Go backward again. Let's go. Stay right there. Go back to that one. Okay, that's good. Right there. That's fine. Let's just take this. Okay. So here we go. Do you see here the red dot? That's the axis of motion at that one lumbar spinal joint. Can everyone see the red dot? Okay. Do we see these fibers are going anterior to that red dot? Those fibers do flexion. They're in front. Yes? Okay. Going to the same vertebra, L5, L4, L3, L5, L4, right here, L4. Going to the same vertebra, these fibers are going behind the red dot. They do extension. Some authorities, some kinesiology experts divide the psoas major into the fibers that go onto the bodies and the fibers that go onto the transverse processes. And in fact, in one study that was done in 24 out of 24 cadavers, the fibers that went to the bodies had a separate innervation. The lower alpha motor neurons were separate motor units from the fibers that went to the transverse processes. In other words, the nervous system divides the psoas major into body fibers and transverse process fibers. In other words, it divides it into flexors and extensors. Does that make sense? Okay, I'm not sure which way to go. Go back toward the beginning first. Okay, now go back this way. So go 1, 2. No, that's the beginning. Move forward now. Keep going. Okay, let's stop. Go back 1 now. Okay, now let's take a look at this. This is a lateral view. Can we see that most of these fibers are in front of the spine? Therefore, they're flexors. They're in front, and almost every fiber is in front of L5. That means that the psoas major clearly is flexing L5 on the sacrum. But take a look way up here. When you get higher in the lumbar spine, more of the fibers are posterior. That means they're extending. So as a general rule, the psoas major flexes the lower lumbar spine, but it extends the upper lumbar spine, as a general rule. Okay? And one more thing on sacroiliac joint. I'm curious, what is causing that? Is someone moving by the projector?
شباب فوق الستيج حديد كل ما بتتحركوا بضل البروجيكتور يتحرك.
Okay? Okay. If you have a muscle that pulls from its center, it pulls both attachments toward its center, but neither attachment moves, then the muscle pulls it against the body. It's called bowstringing. And that's what this arrow represents. When you pull both attachments and neither attachment moves, the belly pushes inward, and that will help to stabilize the sacroiliac joint. That's just wanted to add that for this slide. Okay, go forward. Okay, stop there. We've already said this. When you're at 50 degrees of flexion, it becomes stronger as a hip flexor. Next slide. Okay, great. Now, when you change the curve of your lumbar spine, how do you change that? When you change the tilt of your pelvis. When you increase the anterior tilt of your pelvis, you increase lumbar lordotic curve. This is a side view, a lateral view with an anterior tilt of the pelvis of 45 degrees. People disagree and argue over neutral pelvis, but neutral pelvis is approximately a 30-degree anterior tilt. Meaning, if I draw a line on the base of my sacrum, and I draw a horizontal line, and I measure the angle between them, that's the degree of anterior tilt. It's called sacral base angle. Neutral posture is around 30 degrees. When someone has increased anterior tilt and therefore increased lordotic curve of extension, the muscle moves more posterior. Do we see these fibers here? There's more fibers posterior. So when someone changes the posture of their pelvis and lumbar spine, someone who has lower cross syndrome, excessive anterior tilt, and a hyperlordotic lumbar spine, the psoas major becomes more of an extensor. If someone has a decreased anterior tilt and a flatter lumbar spine, a posteriorly tilted pelvis, this posture, psoas major becomes more of a flexor. The role of the muscle can change if you change its line of pull relative to the axis. That will change if you change the joint angles. That will change with your posture. The point of all this is psoas major is a flexor, or it's an extensor, or it's both. And it depends on the person's posture. It depends on whether it's upper lumbar or lower lumbar. It depends on whether it's anterior fibers on the bodies and discs or posterior fibers on the transverse processes. When you want to understand muscle function or muscle dysfunction, it's really simple. A muscle is a pulling machine. Period. End of story. It's that simple. It simply pulls toward its center. Put a rubber band where the muscle would be. Pull on the rubber band along the muscle. Whatever happens will be the joint actions or motion patterns of that muscle. That's the functioning of psoas major here. Oh, I'll make one more statement. Because the psoas major goes so much over the discs, over the bodies and discs, the spine, it is largely a stabilizer. There's a particular kinesiology book where the author makes a very good statement. She says, whenever people argue whether a muscle has one function or the opposite antagonistic function, the odds are it's not important for either one for movement, it's probably more important as a stabilizer because it goes right over the joint. And in fact, one study showed that in people who have herniated discs, the psoas major is inhibited by the nervous system. Because if the psoas major were to be tight in someone with a herniated disc, it would compress the disc and further bulge or herniate it more. But you can also use that information to say, if you have a patient who you know has a herniated disc, you should assess their psoas majors, because if they're tight, that will further the compression and the herniation. So it might be a very good idea to massage and stretch it. Okay? So the psoas major is the most controversial muscle in the human body. People argue over the psoas major's function at the spine, in the sagittal plane, more than any muscle in the human body. And the reasoning can be figured out if we understand how muscles work. One last sentence. If you really were to say, thank you, what the major function of psoas major is, it is to stabilize the spine when the thigh is flexing at the hip joint. That's its major function. Are there any questions on function? No? Okay. I went way more on function than I expected. So, let's show how to palpate the muscle. Who's my volunteer? Yes, you're a brave man. Okay, let me have you lie down on your back, face up. Okay, good. Well, let's keep your shirt on, but just pull it up. Good. Oh, you have another shirt. Take this off, please. Remove the blue. This lecture is an introduction. I teach 6-hour workshops on just the psoas major. This is an introduction. We can palpate the psoas major with the patient supine, side-lying, halfway between supine and side-lying, seated, standing, and prone. Most people do it supine. 3/4 side-lying is actually the best position, the most powerful. But supine, people do the most. So I'll show it supine and 3/4 side-lying. If we're going, and I'm only going to show for the abdominal pelvic belly, not for femoral belly. I can describe that in 30 seconds if you want, but I'll show for the abdominal pelvic belly. I have to go through his anterior abdominal wall. So I need it to be slackened. I need it to be short and passive, soft and relaxed. That means I want his pelvis in posterior tilt. Because anterior abdominal wall muscles, rectus abdominis, external abdominal oblique, internal abdominal oblique are posterior tilters of the pelvis. So if he is passively in posterior tilt, it will shorten and relax his anterior abdominal wall. Can you go up the table some? Oh. Beautiful. Bend your knees. Bend, bend, bend. More. Good. There. We relax his hip flexors so that his pelvis can fall into posterior tilt. Now, let's go here. So, a guideline. You find his umbilicus. You find his ASIS. You go halfway between. That is approximately where you should be. Exactly where you should be is lateral to rectus abdominis. Will you go follow mice? One more. One more. One more. No, I don't have it here. Go back to the very beginning. Very, very beginning, except for my... Keep going. Back, 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 back. One more. Stop right there. Good. Okay. You must be lateral to rectus abdominis. The rectus abdominis is thicker than the external abdominal oblique, internal abdominal oblique, and transversus abdominis together. So you must find the lateral border of rectus abdominis and then go immediately lateral to that. So can you do a crunch up, a curl up? Yeah, just halfway, halfway. There is the border, right here. And here on this side, relax down. Relax, relax, relax. So I need to go either here for his right side or here for his left. That is where my contact will be. I will always brace my fingers, support. I will get in a good sagittal plane stance so I can lean my body weight from my rear foot to my forward foot. Or I will lean against the table so I can balance against the table. I want you to flex this thigh 1 centimeter. Show me. Do not. Yes. Relax. Relax. Do it again. Show me. That's it. Good. Relax. Good. So, take a breath in and let the breath all the way, all the way, all the way, all the way, all the way out. And all the way out. Stay relaxed. Okay, don't breathe so much. It's too much. A relaxed breath, not just. Okay? And breathe out. And as he breathes out, I sink in. Okay, softer breaths. Someone tell him smaller breaths. Yeah, especially. Okay, relax. Now breathe comfortably. Do not try to breathe so hard. Okay. Yeah. Okay. When he breathes out hard, he contracts his anterior abdominal wall. He's breathing too hard. Okay? Just relaxed breathing. I sink in at a diagonal toward his spine. When I feel his spine, I know I have arrived at the psoas major. I can confirm this by asking him to flex this thigh just a little bit. Go ahead. Perfect. Relax. 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 I felt the muscle harden. Now I know I'm there. Now I assess it. I assess lower. I assess higher. I can go up higher and palpate here. I can go lower and palpate here. 1, 2, 3, 4, 5, 6, 7, 8, 9. I can assess the entire muscle. But you must go slowly. And you must work with their breath. Okay? If you feel the pulse of the abdominal aorta, move a little lateral. Very simple. Okay, this is supine. Okay? Now, can you please... No, wait. Turn to face there. Now, that's good. Go a little bit. Okay, down. Good. Relax. 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 Thank you. Good. Okay. Now, relax back. Now he is halfway between supine and sideline. Just working. There we go. Yeah, that went through very well. The advantage to 3/4 sideline. is that I can use my body weight. Because in this position, the psoas major is directly down. I have to find the lateral border of rectus abdominis. Try to do a curl. Press, press, press. Here. Good, relax. Relax. Got it. Now I have my contact. He is against my knee. Or you can put a pillow. And now breathe in and breathe out. And I drop down with body weight. And there's the psoas major. Okay? Most people are very sensitive, so you would do it slower than I'm doing it. But we do not have a lot of time, so I'm going kind of quickly. Okay? But it's easy. It's body weight. This is the most effective way to palpate and massage the psoas major. If you need confirmation because you are not sure that you're on it, then can you move this hair into here? Try to flex this thigh against me. This thigh. Flexion. Relax. Perfect. Perfect. Relax. 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 What's the word relax? Okay. I only want this much contraction. A little bit against me. Perfect. Relax. Relax. When he pushes the thigh, I feel the psoas major engaged. And that confirms that I am on the psoas major. Are there any questions on supine or 3/4, halfway between supine and sideline? No? Okay. You can do it in other positions also, but these are very effective. Stretch? Okay. Stand up, please. Okay. A moment. So this is what I want you to do. Get this out. We will stretch your right side. So you will find your coccyx, your tailbone. You will put it right here, and you will then lie back. Good. Sorry. Good. Now relax. Relax. Okay. If I put his foot against my clavicle, then I can support him to stabilize his pelvis. Yes? If his thigh now relaxes with gravity, then I can see how loose his hip flexors are. If I push his thigh further into extension, then I stretch his hip flexors. Yes? Okay. So all I need to do is just push down. Take a breath in, and breathe out. And I can just push down. Now he's hitting a little bit. Come closer to me by this much. That's it. Good. Okay? And there, much better. And I can stretch his hip flexors. But how do I know if I'm stretching psoas major, hip flexor, or one of the other 11 hip flexors? How do I make this stretch go to psoas major? When you say leg, you mean lower leg? This is thigh. Okay, in kinesiology, the thigh is here, the leg is here. Leg starts at the knee, it ends at the ankle. This is not leg, so thigh. Okay, so now go ahead.
The direction of the thigh, if it's abducted or in the middle.
Okay, if I abduct his thigh first, then I will probably move the stretch to pectineus, adductor longus, adductor brevis, adductor magnus. Gracilis maybe, but the knee is bent, so not gracilis. So that will not preferentially get psoas better. If I adduct him first, the stretch will move more to tensor fasciae lati, sartorius, anterior fibers of gluteus medius and minimus. But what you said was good in idea, because we have to change something else. We need to find a difference between psoas major and all the other hip flexors. And that is the key to an effective stretch. You need to find a difference. So what is different about psoas major than all the other hip flexors? Of the pelvis? Well, here, stay, hold. Every muscle that flexes the thigh at the hip joint anteriorly tilts the pelvis at the hip joint. Every muscle that extends the thigh posteriorly tilts. Every muscle that abducts depresses. Every muscle that adducts elevates. Every muscle that laterally rotates contralaterally rotates your pelvis. So that's not a difference. Okay. So, relax. She said flexion of the leg at the knee joint. If I flex his leg at the knee joint, there is one muscle that is a hip flexor that is going to start to scream and get stretched. Rectus femoris. So that will get rectus femoris. That won't help. Does the psoas major cross the knee joint? No. So the knee joint should not matter. We can amputate, we can cut off his lower leg, his leg. It will not change the stretch for psoas major. What is the difference? Of his, thank you. Excellent. And you said it too. Yes? The psoas major is the only hip flexor that crosses the spine. Its strongest, clearest function of the spine is same side lateral flexion. The right psoas major does right lateral flexion. So if I want to stretch it, I put him in left lateral flexion. So stay flat on the table and side bend to the left. He's rotating. He's not staying flat. Stay flat first. Yeah. Good. So he must stay flat on the table. I don't want him to rotate one way or the other. Now he is left laterally flexed. That begins the stretch of every muscle in his body that does right lateral flexion. The right psoas major does right lateral flexion. It has been pre-stretched. We have begun the stretch across the spine. Now, when I push his thigh into extension, most likely it will be the psoas major that will stop, will get stretched. Okay? So I'm just, go back, ask him to go to neutral position. Okay. Now, look at his thigh. Now do side bend to the left again. A little more. Did the thigh go up higher? If it did, that tells me psoas major was the tightest hip flexor, because we only changed psoas major. What would I do if I do all this and I ask him, do you feel the stretch? And he says, yes. And I ask him, where? And he points to his rectus femoris. What do I do if the rectus femoris is stopping the stretch?
Extend the knee. Extend the knee.
Perfect. We extend the leg at the knee joint. That slackens the rectus femoris. And now the stretch is more likely to go to the psoas major. What do I do if he says, yes, I feel the stretch, but he points to his adductor area? Then what do? Adductus thigh. Slacken the adductors, and now push him into extension. What do I do if he says, ouch, I'm feeling it in the tensor fasciae lati? Abduct him, slacken the TFL. So you can work with which hip flexor is the tightest by changing joint angles. Now, one more thing about this. When I put his foot on my clavicle, are you okay? Change. Here, come this way. Is this stable?
Yeah.
No, from this side, no.
No? Okay. So we're going this one or this one? Are we changing? Oh, okay. Same one. Okay. Why did I put his thigh in flexion?
For lateral pelvic tilting.
For pelvic tilt.
Posterior.
To create posterior tilt, but I'm only posteriorly tilting his left pelvic bone, his left ilium.
Yes.
I'm not posteriorly tilting his right pelvic bone.
Yes. Because you are affecting the sacrum.
Because I'm affecting one side.
One side.
So now there's motion at the sacroiliac joints. If his sacroiliac joints are healthy, that's fine. But if they're not healthy, this could cause him pain. So then I would need, what's that? Pillow? Pillow to hold him back in posterior tilt? What?
Or change the position.
Well, I mean, I have another choice, but I'm just trying to understand these suggestions. So if we are going to push the thigh down in extension, we're going to create a pull of anterior tilt on that pelvic bone. Yes? If one pelvic bone anteriorly tilts and the other pelvic bone is posteriorly tilted, then there will be motion at the sacroiliac joints. The only way, and if they're inflamed, in pain, that's not good. The only way to prevent the problem is to keep the same side pelvic bone, stop it from anteriorly tilting. Well, there's one way that can be done. Will you go on your stomach? Face in the face cradle? Prone. Prone, yeah. Let's see. It was too high. Good. I'll have you put your arms to the side. Let's see. If I stretch his right side, right here, I bring his thigh up into extension, yes? But his pelvic bone will anteriorly tilt there. So I need to stabilize that. I can put my thigh on over his ischial. Relax, relax. If I put my body weight on his ischial tuberosity, not on his PSIS. That will increase anterior tilt on the ischial tuberosity. And now I lean back. That will stabilize the same side pelvic bone and protect his sacroiliac joint. Okay, and then I get my body weight here, I hold his thigh here, and I cantilever, I balance my body. I don't lift up. Don't help, don't help. Tell him to not help at all. Good. I don't lift him up. I lean my body weight back. Okay? Okay. You can, thank you. Shotgun. You can add in PNF, contract, relax, agonist, contract, MET, ART, whatever name you call stretching, you can add those in, but those you just add in to the positioning of the stretch. You could have him first laterally flex to the opposite side. Yes. Yeah. That will always increase and preferentially stretch the psoas major more than the other hip flexors. Okay? So I'll sum up.
Yeah.
Okay. So there are many other ways to palpate the psoas major, and there are many other ways to stretch it. But I am a strong believer that if a muscle is tight, all of it or part of it, then heat, massage, and stretching are the manual therapy techniques that can be done in your clinic to make the muscle looser and healthier. Certainly if the muscle is weak, and because it's weak, it cannot meet the demands, the challenges that you place on it, that might make it tight. So making it stronger in the long run is always a good idea. But immediately, you can use manual therapy, heat massage, and stretching. And these are some ways to go ahead and address that. Are there any questions or comments? No? Yes. Come back. Prone is actually the most comfortable for the patient. It's the heart, it's perhaps the table needs to be a bit higher. The muscle's right here, correct? I want you to stay with his face in the face cradle, but I want you to come to the side. Okay, if his neck is healthy, then he can come out of the face cradle, if his neck is healthy. Now, I find the lateral border of the rectus abdominis. This is a harder position to find it. But if you can feel it, because you experienced, then you can find it. It's right here. I get my elbow against my core. Oops. Can you picture the direction of force I need to get to the muscle? It's diagonal. My elbow has to be lower than the table. Yes? Now, take a breath in and relax and let it out. And I sink, oh, wrong hand. I have to use this hand. No, you do nothing. Nothing. I go into the muscle here. Once I am near the muscle, I use my other hand on his PSIS or my elbow, and I rock him into my hand. Can you see that?
Yeah.
And because there's movement, the patient is more relaxed, And because you're moving him into you instead of you into him, they tend to be more relaxed. And for this muscle, that makes a very big difference. A lot of patients fight you going into the muscle. So this position is the most comfortable for the patient. But there's no body weight. Your fingers have to be strong. You're going up against gravity. It's harder to find rectus abdominis. It's harder to have him flex the thigh at the hip to confirm you're there. And if he has a lot of fat, it stays in the way, right? 3/4 sideline, the fat falls away. Okay? You're welcome. Okay. So, thank you very much, folks. Shukran.
ثانك يو دكتور جو، شكرا لكم. بتمنى وانتم طالعين بس تشيكوا على الاسماء اللي ما سجلوا اونلاين او اللي سجلوا، كل جميع مره بس ياكد حضوره. بدنا ناخذ صوره جماعيه. تفضل.
Thank you very much.
You're very welcome.
طيب هذا ينزل هون ونعمل شوي طبقات.
Ama